morning, everyone. Welcome to our show, Look and Feel Great with Becky. This morning we've got Dr. Robert Briggs joining us, and we are discussing a topic today that Dr. Briggs has become quite an expert at. We're talking about migraine headaches. And, you know, this is something that affects a lot of people, men and women. I know you see that. I know for myself, I've only had, I think, 2 migraine headaches in my life. And, you know, I had to lock myself in the bathroom just to block out the noise of the traffic on the street. And, you know, I just can't imagine these people who suffer from migraines all the time, you know, several times a week. So we're going to define, you know, what a migraine is, migraine headache, what a chronic migraine headache is, what we do to treat it. So Rob, I'm going to let you take it away. And, you know, first of all, tell our viewers, what is the definition of a migraine headache?
Okay, I could certainly go on for a long time. I think headaches are one of the most common problems that most doctors see. Fortunately, most headaches are what we would call tension headaches. So those are they're bilateral on both sides of the head, often vice-like or a tension around the head, a band-like headache that you hear about. They're usually not associated with nausea or vomiting or any kind of neurologic symptoms. They're usually mild to moderate, often found in people with tension or stress or with pre-existing injuries, whiplash-type injuries. So they're quite a bit different from what we would call the typical migraine headaches, and I think people probably overuse the term migraine headaches.
I agree, yeah.
Migraine headaches are actually found in about 18% of women and about 6% of men. They tend to be unilateral, moderate to severe, even incapacitating, lasting for at least 4 hours at a time. Oftentimes they're brought on ahead of time by what we call an aura. So those are actually neurologic symptoms, whether they're blind spots, smells, sensory changes that people actually feel before they get that very severe migraine headache. Severe reactions to sound and light. People just have to sort of cloister themselves away from light, away from sounds, and really they're incapacitated.
And so
it's
those triggers they're different for everybody.
Absolutely. So some people it will be certain foods, some people it will be weather changes. For women it's often menstrual changes. It can be alcohol, it can be stress, it can be a number of different things. It's very variable.
Okay. So we'll talk a little bit about, again, back to that term, sort of chronic migraine. What's the definition of a chronic migraine?
Well, chronic migraines are migraine headaches that are so severe, and we see a lot of people with this problem, that they're actually having chronic migraines more than half the days of the month. So greater than 15 days of the month, they'll have these incapacitating headaches, which last, at least 4 hours in length. And they're very typical of the typical migraine headaches, though in some cases the headaches are mixed as well. But the bottom line is these are really incapacitating headaches.
And so part of that 15-day, sort of qualifier to have chronic migraines, I believe it includes sort of the pre-aura, the post-nausea, because some people are actually incapacitated for a few days after a migraine like that. Is that right?
Absolutely. And in some people, they say they virtually have a headache all the time. Those are extreme cases, but some people, as a minimum 4 hours, but some people it goes on for a day and a half. So you can imagine just how much this affects people's quality of life. And the truth of the matter is we don't have great medications to treat them. The triptans like Imitrex and Zomig and Maxalt and some others are certainly much better than what we used to have to treat headaches. And they can actually interrupt the headache sort of midstream. Certainly it's better if you take it as soon as you get a warning that you're going to get that migraine headache. The problem is that they are associated with flushing, dizziness, fatigue, and many of my patients say that they can take it, but they're still incapacitated, so they're still unable to work, which of course is a major issue for them.
Are you finding that the patients that you're treating for the chronic migraine program with the neuromodulators, are they able to decrease some of those medications that they're taking?
I've had fantastic results to date with my patients with the neuromodulators.
Okay.
Typically they come in every 12 weeks and we have a number of injection sites, but I find that very quickly their headaches are decreased drastically in intensity and certainly drastically in frequency. Now, that's the normal patient. Some patients don't react, but I do find that's the minority. You really have to treat them through 3 injection cycles, which would be 12 weeks, an initial injection, 12 weeks, a second injection, 12 weeks, a third injection, until you know that they're not going to be responders. And interestingly enough, though most people respond initially, some people don't respond until that third injection cycle. So it is a little variable.
And is that because those muscles are being relaxed?
It's really hard to say exactly why that is. Certainly the thought is that the neuromuscular modulators interrupt the pain pathways, even though we inject very superficially, and it's those pain pathways that ultimately cause a release of those pain mediators and also release neurotransmitters which cause dilation or swelling of the blood vessels on the brain, on the top of the brain, which actually have those pain receptors.
Okay, so let's kind of narrow in on this. We keep referring back to the chronic migraine program. What is that program?
Well, the chronic migraine, first of all, you have to meet the definition. So if you're having chronic tension headaches, and certainly not migraine headaches, you wouldn't qualify. They certainly have to meet that definition of chronic migraine headache, which is pretty tight. You have to have 15 or more headache days a month, and the majority of those headaches have to be your typical migraine headaches, as you've already mentioned, as I've mentioned.
Okay.
So they have to meet that, and that 15-day on average spans over the previous 3 months.
Okay.
So it can't be just a bad month, for example.
Okay. Most drug plans now do cover the cost of the medication, correct?
That is true. So the medication, the neuromuscular modulator, is covered by insurance companies. We rarely get any problems with the insurance forms. Of course, you have to jump through the hoops to fill in with the various insurance forms, and they're all different.
Okay.
But interestingly, Alberta is the only province in Canada where the injection fee for the physician is actually covered. Now, I know in some cases doctors charge above and beyond the injection fee, and I think that's variable according to where you go. Certainly in EA we don't. We only charge Alberta Health for the injection fee, which we're very lucky as citizens of Alberta, knock on wood to date, they're covering the injection fee, but the only province in Canada which does so.
Yay, Alberta. So I know that we keep going back to this term neuromodulator, and for our viewers, we just to let you know, because of pharmaceutical regulations, we're actually not allowed to give you the exact name of the drug and associate it to what it does, so that's why we don't make reference to that. However, if you want more information on the drug, I believe we've included in the comments the website that you can go to. So it's actually www.botox.ca, which is the Canadian site, and there's a drug identification number that you have to plug in there with your email, and then you can actually get more information on the specific drug, the side effects, a little more information kind of in that regard. Definitely speaking directly to a physician, the physician can share that information with you for sure. So we'll have you do that if you want more information. Also on our website, there's more information there. Now, patients that come in to see you, not everybody obviously is going to qualify for the chronic migraine program. I know one of the things that I really appreciate about you, Dr. Briggs, is that when you're speaking to patients about headaches and migraines and all of that, you don't just prescribe the medication. You talk to them about so much more, because we know that there's so many other factors, again, that can trigger, like, sleep issues, hormone issues, nutrition issues. So I was hoping that you could just touch on a couple of those things, and maybe even for those patients who don't qualify for the migraine program, maybe what some, non-medication alternatives are.
I'd just like to walk back just a little bit, because I think that sometimes in medicine we can jump to conclusions. So I think it's important that when your family doctor sees you, or another doctor like myself sees you, that at the back of my mind and your family doctor's mind, we want to rule out any serious causes of headache. We can't just jump to the conclusion it's a migraine headache. So now these are very uncommon or relatively uncommon causes, but there are some what we would call red flags in terms of headaches. So for example, if you come in with fever, chills, and neck stiffness, we're not going to assume that you've got a migraine headache. We want to rule out something like meningitis. Similarly, if you come in with complaints of serious neurologic symptoms, sensory problems, weakness, perhaps you've had weight loss, some other issues, maybe the headache is worse when you lie down and you cough and you sneeze, we would want to rule out something else like a mass lesion or a tumor. Now, again, these are very uncommon causes, but we always have to keep those in the back of our minds. So oftentimes by the time I see a patient, they have been worked up by their family doctor. They have seen a neurologist to make sure that they've been optimally treated. And usually they've had a CT or MRI scan to be on the safe side. So I just want to put that out there because there are potentially some serious causes of headaches that we would want to rule out.
Well, I think it's important just to even point out that, both of our physicians on staff, both yourself and Dr. Savitsky, have been trained by the neurologists that work for Allergan, so I think that's important that you're following the actual chronic migraine program as recommended.
Just like any modality, neuromuscular modulators aren't for everybody. For example, because of the nature of where they work, they basically interrupt communication on a temporary basis between the nerve and the muscle. If somebody has a disease of that neuromuscular junction, unfortunately they're quite rare, but they include ALS or Lou Gehrig's disease, something called myasthenia gravis, Eaton-Lambert syndrome, or if you're pregnant or breastfeeding, you're just not a good candidate. We don't want to do anything that's going to make an underlying condition worse. And as per any medication or intervention, there are always side effects or potential side effects, not dissimilar from using neuromuscular modulators for other purposes.
Cosmetic reasons, yeah.
Like cosmetic reasons.
Yeah.
So we have to be aware of that.
So if you can just maybe show our viewers, either on yourself or on me, where those injections go and what muscles are they really affecting?
Well, exactly. There's a number of muscles, and everybody's a little bit different. So the protocol can vary according to where your particular migraine headache affects you. But typically, we do inject in the frontal area.
Okay.
We inject in a temporal area, just over the ear, on both sides. We inject in the occipital area, so at the very back, and that's very effective, especially if people do have some of the ocular symptoms of migraine headache. And then we inject as well down the trapezius muscle as well. And again, these are often trigger areas. Stress is often a trigger for migraine headaches. So it's a total of 31 injections, but the injections are very superficial. So even though it is 31 injections, it actually moves very quickly. And
they're pretty tiny pokes.
They're pretty tiny pokes,
I don't think we get a lot of complaints. I think people are so happy with the relief that they get that the actual treatment sort of is not. It's not a factor to prevent them from doing it, for sure.
Absolutely. And the one thing that really has surprised me, there are two things that surprised me about the chronic migraine treatment. Number one is just how effective it is.
Yeah.
There's very few modalities that certainly as a family physician I've used that are as effective as chronic migraine prophylaxis.
And I think the statistics, and correct me if I'm wrong here, but 70% of patients get a 50% improvement.
And in fact, I have to say the results I've noticed have been far superior to that.
Okay, great.
So that's interesting. And the other thing I was going to say, I just forgot.
Sorry, because I interrupted you. That's what I do. Well, you know what?
It'll come back to me.
Maybe some of the, maybe one of the reasons that you, in my opinion, I think you get such great results is, again, you're not, just giving the medication to the patient and telling them to come back and see you in 3 months. You are encouraging them to, really address their sleep and their nutrition and some of those other things that, if you can address those, we're going to get a better result.
Right.
So let's talk about sleep.
Okay, I was just going to say, I remember the other thing I was going to mention.
You remember now. Okay.
And that is that it's interesting, the 12-week protocol.
Okay.
If people miss that by a week, it's interesting. They oftentimes get symptoms, or even in some people, towards the end of that 12 weeks. So
interesting.
The company really did their homework, they did their research, because it is pretty much bang on.
Well, and you know what? I've actually heard that some of the drug companies are actually notifying the patients, to make sure that they've got that next appointment booked. So maybe even the drug companies are seeing, I don't know, maybe a reduction in their costs if these patients aren't on a multitude of medications and they're actually getting results.
Right. Exactly.
I think even if we're seeing, improved productivity in patients, that affects the drug companies.
Well, that's a huge issue, right?
Yeah.
So if you're no longer taking nearly as much time off work,
Yeah.
I mean, it's much better for you as an individual to be working and feeling gainfully employed,
Yeah.
but it's much better for your employer as well to
Absolutely.
have an employee they can count on, who's at work. Right?
You know what? Interestingly, I remember back to the true migraines that I have had. It was when I was working shift work as an RN at the Royal Alec, and so I believe that obviously is a trigger. Poor sleep or improper positioning. So I'll let you talk about, what can we do to actually improve our sleep?
Well, that's a great point, because in particular, I'll talk about tension headaches for a moment, because oftentimes they are intertwined with migraine headaches. I find, because so many of us are sitting at desks all the time, and we're hunched over, and we're not using ergonomically correct workstations, and I'm guilty of this too. Our head carriage goes forward, and it puts a lot of strain on the muscles of our neck. And I think the worst thing you can do when that happens, obviously you want to correct that, tuck your chin in, do all those good things that you're supposed to, lower your chair so you're at eye level with the computer. But you also, when you go to sleep at night, you don't want to be sleeping with 3 pillows underneath your neck, which are going to further exacerbate that problem. So what that does is, number one, it puts even more tension on those muscles, makes it more likely you're going to have a trigger for a migraine headache or worsen your tension headache. And the other thing too is it can actually put a lot of pressure on your discs, so you're going to be more likely to have a disc herniation. So we have to be cognizant of that, the ergonomics at the workstation, and also using a thin pillow. I've changed. I used to have 2 pillows that I would sleep with at night, and I was having a lot of what we call torticollis or wry neck. So when you wake up and you can't move your whole body. So I found in the last 2 years I've switched to a small pillow like this one, and I never have that problem anymore.
Well, I know these pillows here, Dr. Briggs is pointing to the Envy pillows that we carry in the clinic, and it's a memory foam pillow, but it's scooped out, and I know a lot of chiropractors are using them now as well, because they actually keep the spine in alignment. So whether you're on your back or on your side, you're in alignment. And I know I've been using it for years, and I think back to all the times where you wake up with a kink even, and I actually heard a comedian make a comment. He says, you're getting old when you wake up with a sleep injury. And I'm like, yes. So these pillows actually are awesome at that. We do carry them in the clinic, but you can also go online if you want information about the Envy pillows. What else for sleep?
Well, there's a couple of natural supplements. One is magnesium, which is one of my favorite. It's also, magnesium is one of the, if you look on the Health Canada website, magnesium is one of the nutrients that most Canadians are deficient in. Anywhere from 20 to 30% of us are deficient in magnesium. Extremely important for a number of reasons, but it's great as a muscle relaxant. So I recommend my patients take it at night, 500 milligrams at night. It will help you sleep. It also, strangely enough, decreases blood pressure by the same mechanism. So it's something we should all be on, I think. And I certainly take 500 milligrams of magnesium every night. So it is known.
I can add something that magnesium, especially in the 500 milligram dose, is awesome for bowels. So if any of you are suffering from constipation or anything like that, it cleans you out. It works like a charm.
Constipation and migraine headaches.
Well, and there's probably a connection there too, right?
Exactly.
Okay, what else do we have?
So magnesium. Melatonin. Now, I know some people unfortunately cannot tolerate melatonin. I love melatonin.
Me too.
It also helps to form glutathione, which is the most important free radical scavenger in the body, binding up to all those toxins that can cause DNA damage and other injury to cells. Melatonin is an excellent for headaches as well, and can help to prevent that. I take 20, 30 milligrams of melatonin. I tell my patients to take up to 10 if they can tolerate it, but melatonin is very, very good. And it's a natural hormone, of course, released by our pineal gland.
Right, which in time, as we get older, our body naturally produces less of it. I know I hear people say, well, I don't want to take it because whatever, but naturally we're actually producing less.
Right, and it helps you
put it back in. The other thing that I have read about melatonin is, because there's, I think, about 10% of the population, they're sensitive to it. So they might have vivid dreams and they just don't like taking it. And I read once that you can actually quarter a dose, and start with a super, super tiny dose and almost kind of work up a little bit. And quite often that really, really helps.
Well, exactly. And I think, even myself, I take melatonin and it gives me vivid dreams. I mean, they're good dreams, but they're vivid dreams. But some people who can't tolerate it, there's a couple of options, like you said. And also the extended release melatonin is usually better tolerated as well.
I want to talk just a tiny bit about hormones, because obviously we do the bioidentical hormone program here. And I know that you have seen many of our patients who maybe not necessarily were chronic migraine sufferers, but definitely the PMS headaches, and they get such beautiful relief from that by having their hormones balanced. So obviously we can do sort of the prescription route, but on the natural side, what can we do to help balance out those progesterone and estrogen levels? Because it's usually those going up and down drastically that sometimes can trigger headaches.
Exactly. That's a great point. And we know, as I think my previous appearance on your show, that as women get older, and by older I mean in their 30s and 40s, that's not necessarily older, as they age gracefully, their progesterone levels go down, their testosterone levels go down, and sometimes they can get this estrogen excess. And there's also a lot of estrogen in the environment that we talked about previously, right, that we should all be aware of. But it's these wild swings in estrogen in particular, and the moderating influence that progesterone can play, that triggers migraine headaches in many women. So, around their periods, around ovulation, where you have these rapid changes. And then, of course, as women move into that perimenopausal period, the last, in the late 40s, the last few years before menopause, they have huge swings of estrogen. So we often, people in the DHRT program that I treat, we can modulate that by adjusting progesterone, which also improves sleep and does some other things too, to adjust that. For women who are a little younger, though, I think there's some other alternatives, whether you need progesterone or bioidentical progesterone, or you just use some of these supplements like Vitex is one, which increases your natural progesterone.
Vitex in the EstroSmart, I can't remember.
I believe so, yes. And EstroSmart as well is one of the Lorna Vanderhage supplements which increase natural progesterone, but they can help to modulate the levels of the hormones which can trigger the migraines.
Yeah, I've heard good feedback from our patients there.
Exactly.
So, we have a comment?
Yes. Natasha is wondering, will this treatment ever cure migraines, or is it something that you'll have to do forever?
I don't think we're ever talking about a cure for the migraine headache, but if we can prevent migraine headaches, it's the next best thing to curing. Now, we're probably not going to prevent all the migraine headaches, but again, if we can decrease frequency, if we can decrease severity, then that's a huge improvement, and that means that you're spending a lot less on other medications, and you're going to be incapacitated a lot less as well.
And I think, is there an age factor, where we see sometimes women who really suffer, they are 30s, 40s, early 50s, but sometimes they get over that. I know my own mom suffered horribly with migraine headaches throughout her 40s, but once she got through menopause, none.
That's right. So estrogen basically shuts off at menopause. Now, we think we should replace estrogen for many reasons that we've covered before. But the key is that when we do supplement with estrogen, we have a stable level of estrogen. We're not getting wild swings throughout the cycle.
Absolutely. So one more trigger that I just want to touch on real quick is, that nutrition component. And, we've done the food sensitivity testing here for a while, and, we just encourage our patients to eat clean, because I've heard and read that there's a lot of people who, are very sensitive to, additives like sucralose or, any of those chemicals. MSG is a huge one for people. So by eating clean, all we mean is just eating real food. If you're not eating packaged food, then you're drastically, reducing those additives that you're getting in your diet. So we encourage people to, either just experiment on their own, and you can just Google it or go to Pinterest on eating clean and get tons of ideas. But really, if you're eating food that doesn't come in a package, you might have a huge relief in symptoms as well. So, alrighty, so patients, quite often they don't know if they, for example, would qualify for the chronic migraine program, or what they do. Sometimes they are, maybe not getting that help from their primary care physician at this time. So we encourage them to book an appointment with one of our physicians for sure to come in, and you guys will do a full assessment and let that patient know, and then you can kind of move forward from there if you think that they qualify.
Right. Some people don't qualify for a number of reasons that we've covered, but we certainly don't want to give anybody a therapeutic modality that they don't require. So we need to screen carefully.
Yeah, absolutely. And like I said, we did post the Botox link so that you can actually get more information on the medication itself. For our viewers, if you know of anyone who is suffering either with headaches or chronic migraine headaches, please share the video with them, give them some of the contact information. Thank you very much, Dr. Briggs, for sharing all that awesome information with us. Next week, we're going to be talking about skin treatments. One of the things that we hear over and over and over again is patients are so confused about what treatments are available, what they do. I think in our industry so often there's treatments that kind of overclaim what they can fix. So I'm going to have Carol on our show, and she's an absolute expert at not only lasers but skincare. She's been in the industry for almost 20 years. So we'll talk about that next week. So pre-plan any questions if you have about skin treatments. And I think that's all we have for today. So thanks again, Dr. Briggs. Bye.
Thank you.